Okay, well, good morning, everybody. It's 8 o'clock and we hit our magical 30 participants. It seems like there's 30 people who are always on time and then a number of others who trickle in as the hour continues. So today it's my great pleasure, first of all, to announce that we saved the best for last. And our last speaker for Pathology Grand Rounds 2020 is Dr. Brandi McCleskey. And I'm sure everybody's happy to see 2020 come to an end. We will still be via Zoom, at least in the beginning of the year. We've started to put together the calendar and you should be receiving that hopefully before the end of the year. We will take, it looks like the next 3 weeks off before we resume in 2021. So today, as I said, Dr. McCleskey will be talking to us. She started her training, her collegiate training in Arkansas State before receiving her MD from the University of Arkansas. And then we were fortunate enough to recruit her to UAB, where she completed her residency and continued on through her fellowship. And I think she liked us enough, and we were fortunate enough to retain her as an assistant professor just 3 years ago in 2017, where she's really and quickly made herself indispensable for pathology. She's currently the director of the longitudinal program in pathology curriculum. And I saw that just this year, which has to be a trying year to have the second hat, is a School of Medicine representative in the UAB suicide prevention leadership team. I can only imagine the increased need for that this year. She contributes to UAB mission as primarily from the clinical side as the Associate Coroner Medical Examiner of Jefferson County. And as you'll see today, she really has a passion and drive for education, which I've gotten to see the last few days setting this up. With her clinical hat, she's performed well over 600 autopsies and has appeared in a number of court cases, both in front of a jury as well as a judge as expert witness. From her mentoring and teaching roles, what I found most impressive is it's not just teaching the residents. Her passion for education trickles all the way down to the high school level and everything in between. And what's impressive from her CV is not only does she have all these clinical duties and teaching roles, she still manages to publish a number of papers, has a number of other manuscripts pending, as well as a number of published abstracts in other areas such as the role of addiction and overdose and the deaths in our community and beyond. So with that, would you please join me in welcoming Dr. McCleskey, and I will hand the mic over to her. Thank you.
Thank you, Adam. It's always fun to sort of get to hear about your journey. I first want to thank you guys for inviting me. It's exciting to sort of be finishing out the Grand Rounds tour for this semester. I also want to say a special thank you to some of our guests that are logging in from afar, particularly some of our resident applicants for this cycle and many others. So hopefully you guys enjoy it. Let's see. All right, so the title of my talk is Back to the Future, Expanding the Gateway to Pathology by Returning to the Medical School. So some others also refer to this as the pathology pipeline. Of course, I have no relevant financial disclosures, but I do want to have a little trigger warning. Here it is, 2020. I may get a little too excited. I'm fairly passionate about this topic, and so I don't want you to take offense, but there may be some distressing topics that we'll talk about today. I like to give you a roadmap of where we're going. So I think in order to know what we're going to do for the future, we have to know where we came from. So we'll have a little bit of a history lesson, talk about where we are now, and if it has affected us at all and what maybe we could do for the future. I'll be sort of driving this journey along this journey today, but I'll have a few special guests to really drive the points home for me. So just to sort of look back, you could take pathology all the way back to the Egyptian embalmings, right? Before the Common Era, when they would embalm the kings and the pharaohs, but there's very little records that remain from that time. And then you can move into the era of Hippocrates and Aristotle, who really even then described inflammation and tuberculosis. And then the Alexandrian Greeks, who made significant contributions to both anatomy and pathology, and even as far back as a Roman writer Celsus, who described the classic 4 stages of inflammation that we still talk about. Galen was one that came right after the turn of the century, or the Common Era rather, and he followed the Hippocratic theory and really expanded the value of animal dissection, and we do have some records from these times. But really, since human dissection was outlawed at that time, medical knowledge and advancement stalled for quite some time, until the Italians finally recognized human dissection and the value of that in theaters such as the one you see here. And then again, we hit another road bump or roadblock. And then in the 15th century, we have Antonio Benevieni, who performed and recorded findings from his autopsies. And then Jean Fresnel, who was a mathematician turned pathologist, who actually diagnosed a case of acute appendicitis through autopsy. Later on in the 17th century, William Harvey really revolutionized medicine and disease with his publication, and then moved on to Bonnet's account of more than 3,000 autopsy reports. And these were really driving the advancement of medicine at the time. It wasn't really until the 17th century that Morgagni, who's really regarded as the father of anatomic pathology, published his complete integration of over 645 or 646 patient accounts, both the clinical and the pathologic correlations and the autopsy findings. This really set the stage for the organ basis of disease, and that really continued on until the mid-1800s. Bailey, following his uncle John Hunter, who's a very famous surgeon, published this beautiful textbook complete with pathology images. And then we move into the 1800s with Bichat and Hodgkin, who then began to publish their tissue-based observations. The mid-1800s are notable for names such as Moeller, Rokitansky, Virchow. Of course, the advent of the microscope and really an explosion of cellular pathology. Virchow was a proponent of using those microscopes during his autopsies, and this really created an explosion of more of cellular basis of disease. It still was in the late 19th century, late 1800s, finally professors of pathology were being recognized by medical schools. Before then, many different types of doctors did autopsies, but it was really that histopathologic, the microscopic description that was setting them apart. Here you see von Recklinghausen, who was an experimental and anatomic pathologist who really left his mark on all of pathology, from bone pathology to uterine pathology to, of course, neurofibromatosis. And then we really hit our stride. So in the late 19th century and the turn of the 20th century, we have Klebs, who really established the link between bacteriology and infectious disease, describing endocarditis. Conheim, who described the origin of what was called the pus cell, and Weigert, who described degeneration and necrosis. Then in the early 1900s, we really start seeing those basic histopathologic features recorded that we still use today. Here you see Mary Read, notably the only woman I've shown you so far, but one that was very pivotal in describing the Reed-Sternberg cell. Aschoff described the reticuloendothelial cell. They went on to Onichkov, who described atherosclerosis, and of course, Carl Landsteiner, who came up with the basis of blood typing that we still use today. In the mid-1900s, fluorescent labeled antibodies, monoclonal antibodies hit the stage, and of course, PCR methods were expanded by Mullis. In the late 20th century, we get an expansion now of a morphology-based diagnostic pathway and really molecular pathology. So you can see that the timeline's not very long to go from the organ system to the cellular system now to really down to the molecular aspects. So now we're in this age of digital pathology and data explosion. And I thought it was very interesting. You know, some of us that are newer to the field think the blue books have been around forever, when really this sort of explosion of molecular data and I guess you could say chapters to the blue books is really due to the advancements in the 2000s. So, when I was going through this, I thought, well, this is a really exciting history, and it shows that we're not, although pathology has been around for a while, we're really still poised to do a lot of greatness. And so I thought this was a very nice segue into what's coming is, when you think about what we've gone through, especially this year in 2020, pathologists really are the reconnaissance teams. We determine the enemy disposition, the intention, the composition, their capabilities, and we help devise a strategy for attack. And that it really, to continue our relevance, we need to maintain active involvement in continuous medical research and continue to progress the field of medicine. So let's talk a little bit about where we are today. So I'm going to talk about the era that we know, which is pre-COVID. Of course, COVID has revolutionized a whole lot of our field, but healthcare expenditures have always been increasing, at least in the recent past, at substantive rates. But really, when you look at it, which they did in 2018, you see the charts here, the lab tests actually only represent a minimal amount of those expenditures, but what we influence is vast. So over 94% of the structured data in the electronic medical record is due to laboratory tests in general. Those tests provide the basis for over 70% at least of medical decisions. And in those patients with infections, neoplasia, myocardial infarction, drug monitoring needs, mostly inpatients, it informs decisions in almost 100% of them. So we're vital to patient care. We have significant impacts on value-based care and population health in general. I think that's very clear, especially this year. And so our role really is to balance, the quality with our quality improvement role with quality output. And so you see here on the image in the bottom of the slide, we really have to balance that speed and accuracy of diagnosis with understanding that there's a patient on the other end or medical management plan that needs to be initiated, but our value and the process that we go through should be recognized. You'll see a fair amount of quotes from this 2020 publication in academic pathology, because I think it's really true. The engagement of a pathologist who discusses proactively with both the clinician and even the patient really can drive that value. And without effective engagement from experts, we might continue to contribute to poor clinical outcomes and increased cost. This publication also did a very good job of outlining some domains that we can add value to what we do. And so I thought it was worthwhile mentioning them here. 4 different areas of that: utilization management, so education and consultation regarding test ordering. We do some of that. There's probably room to do more. And it's not just about overutilization of tests, but actually underutilization of tests that contribute most to delayed diagnoses. We really should be increasing our consultative role and working to help develop quality and database support tools for our clinicians. In the world of precision medicine, we need to make sure that we're active in determining the true value of a test and necessitate the expense that's really needed. We should be involved more in research and health services so that we can continue to demonstrate our true value. Because if anything, if we don't scream from the rooftops what we can do, no one else is going to do it for us. We should improve resident training for test assessment, increase involvement in testing algorithms and guidelines in an effort to help reduce diagnostic errors. Of course, the autopsy is the historical starting point, but I think if anything else that 2020 showed us, it's that accurate death certification and compromised mortality data is a big problem. We should be providing feedback to both the clinicians and ourselves in order to learn from our mistakes and really directly engage with patients so that we can continue to improve population health. And that brings me to improving healthcare outcomes. We should be empowered by the data that we have. If anything, we've shown our value in a response to a pandemic, and we should address those needs and engage with payers and administrators and discuss true cost versus true value. There's a lot of ways that we could go about doing this ourselves, but relevant to this talk, we could also just educate future clinicians about how to utilize on utilization management. We could educate future clinicians about the pathologist's role in precision medicine. We could also educate future clinicians on the mistakes of the past so that they don't make the mistakes in the future. And we could educate future clinicians on how to improve population health and healthcare outcomes. If we want to accomplish all of these goals, we could educate future pathologists who can carry that torch on for us. So why are we doing that? Where did pathology go? Where did the pathologists go in medical school? I like to say it wasn't that long ago that I was there, and I had to go seek it out myself as well. The curriculum model really shifted probably maybe 2 decades now into a more integrative model. Some at the time, and even past that time, argued that learning pathology in undergraduate medical education was a burden, that there's really no need for doctors to learn the pathologic basis of disease, which I hope there are a number of eyes rolling on the other side of this camera. But we have to prepare future clinicians for the genomic era of medicine, and they must understand the nature of a disease. Systems-based pathology was actually integrated into the clinical years of medical school in the 80s and 90s, but by 1999, almost 80%, over 75% at least, of US medical schools taught an unintegrated pathology course. We knew in 2001 that didactic lectures with minimal interaction was outdated, and yet they're still a mainstay in the curriculum. This integrative model and a lack of really figuring out where we fit in reduced the visibility of pathology education. And there was a perception that it wasn't happening, and maybe still is that perception. And there really should be, and there really should be representation of pathologists on centralized curriculum committees, because again, if we don't talk about how important it is, no one else is going to. When you think about pathology in general, we've all seen these curves over the last few years, the doom and gloom of our profession. In 2013, I think Rob Boy was the president of CAP at the time, or shortly thereafter, but they produced a publication looking at active pathologists at that time. There were almost 18,000 of them, not all of them board certified. They reported they were working an average of nearly 50 hours per week. At that time, they reported that the anticipated retirement age was going to be 71, and that we would see that retirement peak in this coming year, actually. They revised the publication in 2019 and found that there were, at that time, a little over 21,000 active pathologists, which if you look at their gap that they estimated in 2013, that's really not that far off from where they thought we would be. It was expected that by 2020, almost 5,000 pathologists would have retired, and that we would see a boom in retirement over the next decade with about 6,000 retiring. So in order to address this gap, we really must build the pathology empire, but are we actually doing that? So in 1926, there were very few training programs. But if you think about that history lesson I just reminded you of, there was a boom of pathology information in the mid-1900s. And really, there were about 700 pathology training programs. Now in 2000, that was consolidated to around 150. Hopefully that was a value-added decision, of course. And in 2013, that same Rob Boy publication showed that there were 583 PGY1 positions, generating over the course of 4 years, 2,400 total residents. And what they said at that time was to fill this gap, we needed an immediate increase each year of 8%. And so I've shown you here the 2020 data. We currently only have 603 entry positions, which if you do the math is less than 8% in a total of 7 years. There are 164 programs currently. There are 603 entry positions, and only a little over a third of those are filled by US seniors. UAB hasn't done a terrible job over the last 5 cycles. We've generated 10 entering pathologists, but I would say with an entering class of over 180 students each year, we might have some room for improvement. We need to really drive home the point that pathologists are critical members of the healthcare provider team. We're physicians, we're consultants, we can improve quality, cost effectiveness, but we really have to train a new generation of pathologists who understand the role of pathology and value-based care and precision medicine, And we have to generate the evidence that supports our value and proactively engage in educating not just students and other stakeholders, but everyone within and outside the healthcare system. So what is the pathologist educator? I am among friends when we talk about competing demands on faculty time. There is significant risk for stress and burnout among faculty educators, but it is critical to make a distinction between pathology as a career and pathology as an important medical science. We are vital in the development of physician scientists. The physician scientist research pathway is well under construction here, and we're hoping to give that a new life as we move forward. But we really have to modify our approaches to meet the learner. We can't really compromise what must be learned, which sometimes gets a little fuzzy, but we really need to meet the learner where they are. And in order to do that, you have to know your audience. And so students these days are really, according to the research, are overall very assertive, and they do have high expectations, but they are at a very high risk for stress, anxiety, burnout. I can't even imagine growing up in a world where there was social media from day one. They are very intelligent. They thrive in interactive learning experiences delivered in shorter segments. They are really good at utilizing commercial products, and there are a lot of commercial products that have capitalized on that. They love pre-recorded lectures. They really are starting to value digital study aids more than professors, which is a problem because we really have to train physicians for the 21st century. They have to understand modern decision-making. They have to be able to integrate the what, the factual knowledge, the how, the why, and that really needs to be built on a solid foundation of biomedical science and pathobiology of disease. But overall, we still need to create holistic, empathic, and compassionate professionals who can take care of our patients. So my question is, well, then do they know us? I've described barrier-breaking professors, innovators before their time, Nobel laureates, investigators that really laid the foundation, and a specialty that's poised to thrive in the 21st century. But let's hear from our students and see if they actually understand that. What was your vision of pathology before you started this course? Like when you thought about pathology, what was like the image that came to mind? Do what? The basement, okay. A microscope. Slides. So technical sort of components. What about a person? Did you have a visual image of what the person might look like or the field in general? Research oriented. You can be honest.
You love histology.
Love histology.
Not a lot of human interaction.
Okay. Lacking human interaction. Anything else? Like a blank box, except that doesn't have humans and has a microscope, slides, and it's located in the basement. Good to know. Oh, and it likes to do research. So what you're going to hear a little bit more in this talk are accounts from a course that I taught, and we're going to talk a little bit more about it. But those are our current third year medical students. So what I think that drives us to now is an age of opportunity. So pathology really does serve as the link between medical science and clinical medicine. And we really should focus on educating students on the basics of disease, the relevant, not the rarities. We should emphasize underlying principles and help them understand what the quote unquote, the lab is and what quality control is. That's our expertise. We're a problem solving field, and we should encourage problem solving through diagnostic knowledge. We really can provide integrative concepts at the very beginning of their medical school curriculum. And I see great value in utilizing the gold standard teaching tool, the autopsy, and hopefully you'll agree with me at the end of this. This is another account from one of my students this just a couple weeks ago. The autopsy was one of my favorite things I did in all 4 years of school. And I felt incredibly privileged, not to mention getting my tuition's worth when I was in the autopsy room. Had I known, I would have considered going into pathology. She spent literally 3 hours with me in an autopsy suite, and this is the value that added. So I want to talk a little bit about utilizing autopsy in undergraduate medical education. I know it has been in the past, and I know it's not without its obstacles for the future, but the opportunities really are vast. It's got, of course, the longest record for improving safety and outcomes. It epitomizes problem-based learning by using a variety of teaching methods. We can talk about anatomy, we can talk about clinical pathologic correlation, pathophysiology, death certification, help clinicians understand bereavement and how to counsel their patients on that. Actually, the autopsy in one study ranked even higher than podcasts, which students these days love. And it really, now for the 21st century, we could utilize autopsy tissues and data to help, and next generation sequencing to really help understand the genetic and molecular basis of disease. It, of course, is not without its obstacles. There are a number of efforts for reducing healthcare costs, and there's really no reimbursement there. Of course, declining rates of autopsies is a problem. I would suggest due to reluctant, albeit uninformed clinicians, since they're the ones having to ask for the autopsy. It's perceived as unnecessary or a waste of time, and I hope that's not true of anyone on this call. And there is, across the country, a lack of dedicated autopsy faculty, a lack of time to accomplish this, and really a lack of facilities. We're very lucky here that that's not the case. And so I capitalized on that. I started a course in 2019 called How the Dead Can Teach the Living. Of course, it's a catchy name. The students loved that. The maximum class size had to be increased within hours. It generated a wait list very quickly. And at the end of that, the students remarked that they realized what the patient care role of the pathologist is. Those blank box kids, students from previously, that's their feedback. Now they understand that pathology is interactive. They understand that it's a collaborative field. They understood what the impact the autopsy can have on population health. And I assure you, there's at least 13 students out there who are really leery about mortality data because they understand death certificates are very important. This year's class just ended a couple weeks ago. I had to increase the class size yet again. Of course, it was taking place during COVID and in a hybrid setting, but what was really fantastic is the advent of virtual meetings. And so they got to attend the National Association of Medical Examiners meeting this year and present a topic to their classmates, which they really enjoyed. What you see on the right side of the slide here is the overview or the syllabus of the class, which could really be replicated anywhere. So do you think the experience was worth it?
I think what was interesting to me was the fact that, I entered the autopsy suite and my guy literally, it looked like he could have been sleeping there because he had it was not traumatic or anything. And so I think that was kind of interesting that he looked okay and he died of something that was, relatively preventable. He was only 52 years old. And so the fact that he just never received medical care for hypertension, hydrochlorothiazide is not an expensive drug, but he had never, gone to the doctor to receive any medical treatment.
Struck me is that, we've obviously dealt with our cadavers and done a lot of dissections, but it's so different when you're seeing a body that's only, the person's only been dead for 24 hours or less. I mean, to hold someone's heart that was not beating very long ago in your hands is a pretty sobering experience. And my grandmother was a nurse, and she was telling me that when she was in on deliveries, that was kind of what made her think about like the weight of life and the meaning of it and things like that. And I got to do or help with the special delivery day that the OBGYN group does. And yes, it was a really, cool moment to see the parents happy with their baby. But for me, I think honestly seeing like the autopsy was more of like a meaning of life thing for me. I don't know. I'm sure that's different for everybody, but like the death made me think about it more than the life.
So I'd say they agree that it might be worth it. And I put some topics that are important in medical education these days. Of course, social determinants of health. It seems like our patients, especially mine at the coroner's office, can help teach those. So what else can the patient learn?
I think sort of continuing off of what Mimi said, sort of a similar thing, that it made death like a lot more tangible. And I was thinking about it, sort of some of the criticisms that we've kind of like poked fun at about pathologists, people make about pathologists is like, well, we don't take care of patients or pathologists don't take care of patients, right. And stuff like that. And then another thing, sort of, if you guys remember last week with the talk we had last week, one of the speakers sort of made a joke about how his father's an oncologist, like he wasn't going to go to his office and be like, did you have cancer? You know, how can I trust you to take care of my dad if you don't know? But it's like, you know, we're all going to die. And the cases that I witnessed, and I guess most of the cases there, it's not like these, like the causes of death are like really exotic things. It's like car crashes and house fires, and even I would say even like gunshot wounds and drug overdoses. It's not like some other group of people that dies from this. It's like these are all very common things that could happen to any of us, and we will all have to die at some point. So it made it strangely relatable. Like I actually felt like I could relate a lot to the patients, because it's like that could be me. I mean, it's not that hard.
That's a very good point.
I had like a motor vehicle accident day. The person that I ended up doing an autopsy on was not actually like what got me. I was in there. We had two other men, I guess you could say, but they were 21 and 23, and it was like this was Saturday morning, so they'd gone out and they were like drinking and hanging out with friends, and then they got in a car drunk without their seatbelts and ended up dead the next morning. And it just like was horrible. I just like couldn't even function when we walked in the room, because they were perfect young people that looked just like us. And like, it just got me the whole day, because how many people have messed up and just like driven drunk or not called an Uber or not put on your seatbelt and had no consequence for that mistake. And so I just like, I called my cousins that are that age and was like, hey, just a reminder, it can happen. So I don't know if anyone else had that experience, but I know we're not all perfect and we make mistakes, but don't make those mistakes. Call an Uber, put your seatbelt on, because that was horrible. And those people's families, it's just horrible.
So I don't know if you noticed, but if you watch their faces, they're all very engaged. And I would argue that maybe this experience helped save a few lives possibly, or made more holistic physicians out of this group. So what was the feedback?
I did not like the autopsy. Thought it was horrible. Learned so much though. And so please, when you go pitch this to other kids next year, tell them that they don't have to love pathology and they can like be squeamish when they like your lectures. Super didn't enjoy them, but like learned a lot. So like I've learned so much from this course. I honestly think I could be a pathologist and love it every day, like genuinely. So just keep that in mind when you go pitch it to people, because you don't have to be thrilled about an autopsy to love this course. So glad I took it. Thank you so much.
Oh, God, you guys. I feel like one of the goals that the course had was to change the perspective that we have about pathologists. And I think that really struck me, because I think pathologists are portrayed as people that don't really have patient interactions. From my past experience, granted it's very limited because I'm only a second year, but I think that this course really taught me that there's a lot more avenues in pathology than I thought there were, and that the lifestyle is not what I had perceived it to be.
Doing the autopsy was one of my favorite things that I did the entire 4 years of medical school. So thank you so much for letting us do that.
Okay, yeah, something Meta said reminded me about like changing your perspective. It definitely did about autopsies, and I know you're passionate about what I'm about to say too, but like even the opportunity to hear those two guys speak, like the past heroin addicts, I think was like definitely a lifelong lesson that, you know, if I got nothing else out of the class, which I got a lot else, you know, out of it, but you know, that would be extremely valuable and worthwhile, because it was just crazy. I remember going home and I was telling my wife about it. Like we were supposed to be on a date or something. We talked for probably 2 hours after that about like, my mind was blown because I had no idea like what that stuff actually meant, like what their experience was, and that, you know, people who are drug sick don't really have a choice in what they do. You know, it's crazy. Like, I mean, the way they explained it, I mean, y'all were all there, y'all heard it, but it just definitely blew my mind. Like I did not think about it that way. And it's definitely changed, even like seeing people walking down the street in Birmingham, just like how I think about some of these people and what they're going through. Like I had no idea. So that was crazy, mind blowing, very valuable.
When you guys gave the talks in fundamentals last year, like that was super intriguing, because I feel like most of fundamentals, it's like basic science. And then I think it was either Dr. Dye or Dr. Atherton came in there and gave like a lecture on different types of trauma. And I was like, well, this is something we haven't been able to see yet. Like, okay, here's what, hitting someone with a bat looks like and stuff like that. And that's part of the reason I signed up, because I saw your name on there. And I was like, wait, these are the people who gave the really cool lectures during fundamentals. Like, I would like to, participate in the class and go forward with it. And the autopsy was like really interesting because we were in neuro when I did mine. And we had the brain anatomy lab, and we, got to hold a preserved brain. But then I got to hold this guy's brain that was like producing thoughts 12 hours prior, and, just like feel it and look at it. And it was like one of those whoa kind of moments that I might not ever get to experience again. So thank you for that.
I just wanted the opportunity to tell you that the only reason that I took this class was because I wanted to see an autopsy. And not only did that happen, but first of all, I enjoyed it, and I can't believe that medical students don't get the opportunity to see an autopsy in general, because it's a completely like night and day difference from the cadavers. Second of all, like the timeliness of this course, and much less us getting to do that this year, and the opportunities to do stuff in person. And like, even if you couldn't be in person, like the interactions that we've had with you and the other staff have been amazing, and they've been extremely informative. And my whole perspective about pathology and pathologists has been completely flipped upside down. And it wouldn't have happened without this. And it also I wouldn't have even thought to like look into this if you and Dr. Dye hadn't taught in fundamentals. So that was like the lead in to this course for me. So I don't know where it's going to go for me personally and for everyone else in here, but just know that we will never forget this.
These students just make my heart so happy. So, we can really build off people's interest in forensics. I've told all the applicants, tell everyone we're sort of the sexy side of pathology, but I just want to build more pathologists. So, what else can we do? Since I have all of you here and you're all going to listen to me talk for a few more minutes, I have a few ideas. One of which, this co-enrollment course format exists here. We should utilize it. I've had an idea for a surgical pathology one. I even have a catchy title, MD in Focus. Goals could really highlight histopathologic basics at the scope to really tie into what they learn in the classroom. In the COVID era, we have a phenomenal peer database that Dr. Anderson has built, and we could really utilize a future whole slide images as well as the ones we already have. We could, it could be organized based on the preclinical curriculum. It can be taught by pathologists and residents, but it really needs a course director. It needs a champion. Histopathology practical sessions are still essential to understanding the pathologic basis of disease. My clinical pathologic correlation sessions, which some of you have heard me talk about, and some of you are teaching, they're currently being added to each organ module. There really has been, outside of Dr. Anderson's fundamentals block and a couple organ modules that are run by pathologists who win teaching awards every year, little to no pathology is being taught by the pathologist, and we're a robust department. We should be very active in the medical school. The CPC model is not new. It's been published in the New England Journal of Medicine since 1924 with a team-based approach, a clinician presenting clinical findings and a pathologist presenting pathologic findings and working together on a diagnosis and treatment. It really helps establish connections with our clinical colleagues. It highlights the pathologist, that maintaining visibility part. We're a part of the patient care team, so we need to stay relevant. But these CPC sessions need champions too. Pathology, we don't have to start from ground one. Pathology competencies were published in Academic Pathology back in 2017. They were organized into 3 different areas, and there are topics within each. I've utilized these to help build some of the CPCs that we've already done, but we have an opportunity to do more. The disease mechanisms and processes are more the fundamental concepts. There's a section on organ system pathology, which could really be integrated into all the organ modules. It could help organize the organ modules. It could also provide some foundation goals for the CPC sessions. And then there's a section for diagnostic medicine and therapeutic pathology, which there is an evidence-based medicine module in our current curriculum. we could be present there. The Pathway to Residency course, could you imagine how much more valuable these incoming residents or empowered, that we could empower them to make decisions regarding lab tests and lab utilization and interpretation. And then we have an opportunity, we can have as many co-enrollment courses as we want. We can also use the competencies to help build better structure within our current rotations. We can use digital pathology to augment the hands-on activities we already have. We can work with our clinical colleagues to add to their clinical rotations. What's keeping us out of the surgery rotation and allowing the students to spend the day in frozen or to follow the specimen? I'd argue that that's how a number of us actually got interested in pathology. We could develop self-directed learning modules for students that are going through these rotations. One of my past students sent me an email and said, hey, I'm interviewing for radiology, and they have a really great program where the radiologist can follow the biopsy in the pathology lab. That sounds like a cool idea. I said, yeah, it sure does. OBGYN, we could let them follow the placenta. They could see a perinatal autopsy. They could understand what the pap smear is and why cytology is even involved in that. On the medicine rotations, these students and even the residents, they should see an autopsy. They should follow their patients. It is okay. Some patients are going to die. They need to be able to understand how to manage that. They need to understand what the lab is. We could do self-directed learning modules on lab tests, interpretation, but we really need to be more intentional with consultative pathology. We heard a grand rounds here about 3 years ago from Mike LaPosada talking about diagnostic management teams, and almost came out of my chair then. We should be integrated into the clinical teams. Our residents should serve as contact points for clinicians and patients. Patient access to reports is coming. Let's be proactive. It doesn't have to be a scary thing. Being a relevant member of the patient care team and talking to your patients, I will stand in the front of the line and tell you that it generates well-being and job satisfaction. It might be uncomfortable. I deal with them at the worst period of their life, and yet I still find great value in talking to those patients. And I assure you that it generates better patient outcomes. One thing that we're looking at doing here, if you were to take it back a step, is reinstating the post-sophomore fellowship. I'm not sure what the history is or where it went, but it's a very important tool to integrate both the clinical and the research components of what we do. We're considering maybe adding it as an experience to go abroad. We have international UAB footprints. I think that would be a huge recruitment tool. They could actually learn how to be a pathologist here and then go experience what it's like in a community-based setting in another country. We could even work with UME to help identify these applicants at the pre-matriculation stage and get them engaged early on. Many models exist across the country. And here is a publication that was just in academic pathology last year from Iowa, which is a relatively smaller program, especially when compared to us. But they've had, in 20 years, they've had 126 post-sophomore fellows. 43% of them pursued careers in pathology. That represented a majority of the graduates that actually went into pathology, although they did a fairly decent job otherwise, even outside of the post-sophomore fellowship year. And those who didn't go into pathology still affirmed that it had a positive influence on their current practice. And I would say that's the feedback that I get from my students as well, that regardless if they go into pathology or not, they actually understand it a lot better, which is one of my primary goals. I want everybody to at least make an educated decision about their future rather than just not knowing. So will it matter if we do anything? Will it matter? I guess time will tell, but I think it's important that we not lose sight of our patients and understand that there is a life and a story behind the specimens, behind the disease process. We are not locked up in the lab. We're constantly in communication with each other, with patients, with clinicians, with the community, and we really should highlight that role and help solve diagnostic problems. I think we have a chance to adapt to the opportunities of the future. We had a slump. Let's justify the rise that we're going to see post-COVID and really demonstrate that we are valued and that value will have to be earned. It's not just going to happen naturally. But what I do know, again, this is from the publication this year, is that if we are unwilling to take advantage of these opportunities, it will be viewed as a cost and liability in the same way that perhaps the autopsy has been, and pathology will diminish as a profession. And I'd sure hate to see that happen. So hopefully you guys can join my team of passion players, and the future really has arrived. So I look forward to seeing what we can do. And of course, I would be remiss if I did not give special thanks to my students for allowing me to record them and feature them today. So of course, if you're not following us on social media, please do so. And that'll be that. Thank you.
Thank you so much, Dr. McCleskey. As a non-clinician, non-pathologist, I mean, that was just an overwhelming tour de force and makes me realize what I missed by not pursuing that profession. Your passion definitely comes through.
Thank
I'm
you.
definitely open for questions. She purposely said she wanted to end a little bit early because hopefully this
Looking
sparks some
forward
good
to a
discussion on where
spirited
pathology
discussion.
is going. Yes.
Thank you so much for your talk today, Dr. McCleskey. I had a
Hey,
question.
Monica.
Hi.
Welcome.
Thank you. It's something I'm really passionate about, is improving the pipeline to pathology. Because again, I was one of those people that had a pathologist in my life before med school, and you were in fact a forensic pathologist, and that's just how I got into it. And not everyone is, that lucky. So I'm kind of that obnoxious person in my medical school trying to tell everyone how great pathology is. But one of the difficult conversations that kind of come up over and over again, and it's a conversation I don't know how to answer or partake in, is salary. There's specialties like ophthalmology, dermatology, radiology that don't have great exposure in medical school, yet they're so competitive and so sought after just because of the salary. And I'm curious, what can we do as a field to be more, to improve the salary, to get hospitals to understand the worth that pathology brings, and really also bring that up to I don't know, up to par, but kind of also up there to be attractive to medical students.
I think those are great, excellent points. And I'm glad there's some strong leaders on this call that could help with that. But so from a forensic standpoint, of course, we have a national association of forensic pathologists who are fighting for us, who are trying to demonstrate what value we have. Forensics is probably the hardest one to get, to say, hey, we matter. And, a lot of them are based on county governments or state governments, which is, it's hard to get bureaucrats to understand why people should care about why others are dying. Hopefully COVID can help that. We might as well ride the high since we had to deal with the awfulness. But in general, it's about representation, right? We need people to fight for us. We're all busy. We're all very busy. But if we don't scream from the rooftops why we matter, I feel like we've had this talk. I've been here for 8 years. I feel like I heard it 8 years ago. I'm sure it was said 20 years before that. It's time. It's time to say we matter. I will say salary is not the only contribution that should matter when you choose a career. And I tell all of those students that you just heard from, I tell them that lifestyle matters. And it matters for especially those of us who are young moms, who are females, who are looking at a life that's not just sitting at the scope or working all the time. And so that's a real value that we can add, especially in this era of students like yourself. I don't know if anyone realizes Monica is one of our applicants this year. Quality of life matters, and we need to capitalize on that as well.
I can chime in a little bit. First, incredible talk. Thank you very much. And I'm so happy to see how many people signed out from outside. So welcome all of you. I think also there is a little bit of misconception. Actually, salary in pathology or compensation, if you look at it as a package, is better than it's better than the 50% of all other specialty. So we're really in the upper half. We're not an uncompensated or rewarded from that financial. Of course, I saw so many people commenting about the lifestyle, the others. clearly there are other value, not just the lifestyle. There is also the, we attract the type of people who are inquisitive, who love science, who love to discovery. So all these factors play in, but even the monetary part, it's not is no longer a detriment to us. Clearly, we could be compensated more, and matters if you're in the academic versus private. So there's some astronomical numbers if you're in the private field. And the other thing is with genomics, with AI, the opportunities for potentially more income are coming, and also opportunities for jobs in certain outlets that are beyond the traditional, laboratory, private laboratory or academic school, because there'll be a lot of industry and a lot of rewards to that too. So I think we can use that, but I agree we should always continue to show our value. I think we're in the midst of a third revolution in the field. I know the focus was here on education in this lecture and how to attract people, but don't forget that AI and digital paths, this is a new amazing field for us that's going to enrich us as is doing, and it did in the last decade, genomics. So if you look at these two things, that's huge for us, and it's going to attract a lot of talent. So I'm really not worried. I think we don't do a good job advertising ourselves. But with the change of workforce, which is happening, you just need to look at Twitter and see the pathologists or pathology residents who engage in Twitter and social media versus my generation. So clearly we're going to be a different breed in a decade in a positive way. And those are going to continue to revolutionize the field, and probably with the two areas that I mentioned, will do a better job than us reaching back to medical school and continue to enrich the pipelines.
Thank you. I also want to point. Oh, I'm sorry. Go ahead.
Okay, go ahead, Brandi.
I just wanted to also point out we also have some visitors from South Africa on the call today too. Some pathologists who I just wanted to say hi to them as well. Go ahead, Dr. Marcus.
Well, thank you for a wonderful talk. This was really inspiring and excellent. I just want to share a very a small experience I've had with teaching and publications, and something that my junior colleagues could learn from. So one of the things you need for promotion is to show that people know you, national recognition, international recognition. Well, in 2007, 13 years ago, I published a paper with a former student of ours and resident, Yara Park. She is now the program director of pathology at UNC. And the title is Teaching Medical Students Basic Principles of Laboratory Medicine. I still receive emails from ResearchGate that this is the most read article for our department, several weeks. More than 5,000 reads of one single paper we wrote in a weekend. So people there's so much opportunity because there's so little out there as to how we should be teaching lab medicine. In my case, one of our former residents, Sarah Bean, has been doing cytopathology teaching at Duke. She has some publications on that. So we could actually have another session on all the things that have been done in this regard from UAB. We have a very strong record of teaching, and people are eager to read. So when you're applying for for promotion to associate professor, you want to prove that you have national recognition. Said my article has been read 4,000 times, and you can even say where it was being read. So there's room for so much more for us to do, just sharing the little bit that we know and do here.
I'll just sort of build on what Dr. Neto was talking about, social media, and you think about the new age of publication or recognition. Those of us who are on podcasts, you get it, like I did one session. It had 1,600 views, live views during the education session. 1,600 people heard me talk about how to investigate pediatric deaths. Like, I would argue that that's reason to be excited and to realize that we have an opportunity to have a great outreach.
That shows the difference in age, right, Brandi?
Well, I thought it would be a nice little let's loop it around.
Yeah. That sounds great.
The future is bright.
Speaking of that, for those who didn't grow up on social media, I just want to draw attention to the chat. So for people who haven't looked at that, there's been some good comments. Some have been addressed in the discussion, but for those who haven't opened it, to read through that as well.
Brandi, that was a very nice talk. One of my comment was sometime back, you may recall, lab medicine used to have a scholars week. So we used to have students, about 8 to 10 students used to rotate to various sections for a week at a stretch. And I don't know, that can be relooked at. Yeah, that's one way to interaction.
I offer one, Dr. Reddy. Remember, I've been offering one since 2008.
But that's a special topics, I believe.
Yeah.
So special topics are still part of our curriculum. We have a ton of them. I didn't really go into what we already offer. We have a fair amount of rotations. We all have we pretty much all have a special topics week that people can sign up for.
Okay.
But what I would like to sort of go back to is we are at a point where we could do this remotely. Like, we can do so much. COVID has shown us that we can utilize digital tools, these remote tools, to really get the message out. And so I've talked to just my own organization name about why aren't we having like digital lunch and learns? Put them on Twitter. Like, this is insane. There are people who want to hear about what we do. We should make it easy for them to do so, whether they're here in our medical school or not.
Great.
This is great. Definitely one of the more robust discussions we've had in Grand Round. So I look forward to keeping this momentum into 2021. And again, thank you for all the external people who visited. This will continue on. Are there any other closing comments or discussion points?
I want to add to something that Brandi mentioned briefly, which is the idea, and I see it on the chat too, the idea that patients will be accessing pathology report, which I know we have some trepidation, some of us, if that's like you turn it overnight. So we want to be prepared, and we do have time. But this is a great thing, and that's what Brandi's message, and I know we've had discussions, Brandi and Greg and I, about this. And it's something that we do a lot, and people don't realize, and it's again, I think, depends on the pathologist. So if you get a lot of consultations, it's unusual. They can be sent from your patient. It's not unusual to talk to your patients, and several of our organizations are trying to push that, because this is helpful in showing the value of our fields and importance. I think we got a silver lining with COVID. I don't think a lot of people realize how important our expertise is. The pandemic, I know regionally and nationally, this helped a lot portray the stars that we have in microbiology, in lab medicine, which a lot of people think of it as just machines. They don't realize the connection to a medical scientific professional in our field. So and the genomics, I keep harping on it. The Angelina Jolie effect, I think, was huge for PATH, BRCA, and molecular and diagnostics, and the patent issue about genes that followed, and the Association of Molecular Pathology helped win the day where genes are not patentable. All these things brought attention to the field, and if we continue to be proactive, engage our patients, engage through social media, I think this will be very important for us. And it's like everything; it's a self-fulfilling prophecy. You start attracting the kind of people that are more communicative into the field, and I have to tell you, if you look at now and you see the impression about Path, when I went into pathology, it was. I remember going to my first conference in Dallas, and some of the shapes and figures that I saw, I say, oh my God, who am I joining? Who are these crowd? So things change a lot, and I have no doubt that they will continue changing to the positive in terms of impression and understanding of what we do and our value.
Just so everyone knows, I did, of course, agree for this to be posted on, we have a YouTube channel. Sorry, Adam, if you were going to go there, but I did agree for it to be recorded and posted. So it should be available for your viewing pleasure, sharing pleasure, share it widely, however far it needs to go.
You have to try and get those views above 1,600, right?
Yeah, totally. Hey, I think I did get the most participants though.
Yes,
I love it. I love it. Everyone go talk about it. Get more people into pathology.
Thank you. All right. Thank you very
Thank
much.
you, everybody. And Brandi, thank you for bringing it home with the slam dunk. That was great.
You.
So
Happy
hope to see you all in
holidays.
2021.
Applicants,
Happy
virtual
holidays.
open house tonight. See you. Everyone, sign on.